Thank you. Appreciate that. It's good to be here. I'm thankful for Liberty University. It gives me a place to live out what God's called me to do, and glad y'all are here. There's probably no more important issue for us to face squarely and honestly than the opioid crisis. We've gotten all kinds of messages over the past few years. It is the number one health concern that we need to address in the country. Recent stats, I think, just came out in January. Percentage-wise, you're more likely to die from an opioid overdose than you are in a car accident. And that just changed in January, I think, of this year. So the statistics are horrible. They are overwhelming, and we're going to spend a good chunk of time just going through what are we looking at? What's the crisis? What are we facing? What does it look like? There is no way we're going to cover even half of the content in the handout. The handout is intended to be a relatively freestanding resource for you to use to do your own education of community groups. Students, don't use it in your presentations. If you're gonna, go to your websites. The helpful resources, I think, is the last page of the handout. Most of the information contained is on the public domain websites, the SAMHSA website, the Substance Abuse Mental Health Services Administration website, and the National Institute on Drug Abuse website, drugabuse.gov and samhsa.gov. And so that's where most of the information comes from. That will allow you to stay current. So I thought we'd just take some time to look at the crisis. What is it? What does it look like? What are we facing? Briefly just zip through addiction and what that's like, how the phases of addiction may be different for opioid addiction. And the kind of the point of today really is to get to how can the church help? And so we'll take a little bit of time to do some perspectives, things that we may need to think about differently, and then move into some specifics about how the church can help in this situation. We'll leave some time at the end, 10 minutes or so, for questions. There may be a spot along the way or two where we can take one or two, but that's kind of the direction we're going, okay? All right. The crisis. Over $700 billion a year when you look at alcohol, tobacco, and other drugs. $700 billion a year every year just bleeding out of our economy, bleeding out of the life of our nation. So imagine if a femoral artery is leaking that badly. You're going to be real concerned about the patient, all right? So that's just typically what we're losing, all right? The opioid crisis itself has added, the recent version up until about a month ago was on its own, the opioid crisis adds an additional $500 billion to that total. That's massive. The most recent update, it's $700 billion. And the reason the costs of the opioid crisis were so underestimated is they had not figured out an accurate statistical way to calculate the cost of all the premature death because of the overdose death. It's a happy topic today, right? So just doing the math, just looking at the numbers, you're talking $1.25 trillion every year gone because of addiction generally, and the stats are probably half of that at least is related directly to the opioid crisis. Now, I'm gonna actually jump ahead a little here. The best way to get at what would Jesus do is answer what did Jesus do? And so I really have just struggled with, all right, where would Jesus be? If he was here in the flesh, where would Jesus be? What would he be in the middle of? And I think he'd be in the middle of this opioid crisis. That wouldn't be the only thing, but I think it'd be one thing, right? So, all kinds of different types of opioid medications. I won't go through all of these at this point, but opioids used licitly, meaning according to prescription and according to directions and things like that. And then you've got illicit use of opioids, prescription meds that aren't used appropriately. Oxycodone, your Percocet, and Demerol on down there, methadone. You got all kinds of opioids available. The high death rate is coming from the synthetic opioids, the fentanyl. So we'll see a slide on this in a little bit, but the fentanyl deaths and the carfentanil deaths account for about 60% of the opioid overdose deaths. All right. So it's the fentanyl and carfentanil that are really causing all the dying. Not all of it, but most of it. And that's the stuff that unfortunately can be produced synthetically and chemically, and a lot of it's coming from China into cartels and across our southern border and things like that. So it really, as we think through this, think in terms of addressing supply side and demand side. And historically, we really haven't done very good at that as a culture. The demand side, the treatment people have kind of lobbed bombs at the supply people, and the supply side people have lobbed bombs over at the demand people. And I really believe that God has us in a situation that, in my mind, is very much like how the church had to respond to when Katrina and Rita blew through a number of years ago. When I started thinking that maybe our response needs to be very much like what we would do in the face of a natural disaster that completely devastated a region, one of the ongoing effects that was really a marvelous thing to observe in the Gulf Coast when those blew through was just simply how everybody had to come together. It was that bad. And in the midst of everybody coming together, how the church just simply did the church what the church is here to do. And it made a difference, and it made a noticeable difference. So much so that the federal response people, rather than coming in now and telling the church people how to do it, they're saying, listen, you tell us what you need from us and we'll help you do what you're here to do. So there's actually been a good paradigm shift when in the kind of the natural disaster realm. And I think if we pull some of that forward to this opioid crisis and think of responding in those kinds of ways, I think that may be one of the helpful ways that the church can respond. All right, so number of prescriptions. This is kind of interesting. The number of prescriptions quadrupled. That's times 4, you know what I mean. Quadrupled from 1999 to 2010, yet there was no increase in reported pain. All right, so you have a quadrupling of the number of prescriptions, and yet the reported pain stayed the same. So we've had this surge in the use of opioids and their prescriptions. And of course, opioid overdose deaths and treatment admissions have paralleled that increase. Primary care providers were responsible for about half of that increase, about 50% of that increase. Now, some of that came because of a letter that you can access on your resources page. In 1980, a letter was sent to the New England Journal of Medicine by a researcher and a staff person, a physician, that in a very structured inpatient setting, they reviewed a bunch of charts and a bunch of numbers in those charts in a very structured setting, and came out and said, they wrote a letter to the editor of the New England Journal of Medicine, very short paragraph that said, see, we've got evidence that only a tiny percentage of people prescribed opioids for chronic pain become addicted. And so here this letter sat for about 10 years, 12 years, something like that, and then came the development and selling of the prescription opioids, and all of a sudden you can check the number of references, the number of hits to that letter that people referred to, and those things just escalated and skyrocketed. All right, so this whole thing got started with basically a letter that wasn't systematic research, but other people who had other motives, unfortunately profit motives mainly, started referring back to that letter. And so the word got out and in the medical community that these weren't as addictive as traditional opioids and things like that. And so they were just off to the races doing the opioids. Now, I don't want to hammer the medical community, right? I mean, helping people deal with chronic pain is a worthy and noble function of medical care. And it just, we're at a place where we just have to do it different now. And so that's starting to happen. I won't bother showing you the letter. We're already kind of stuck on time. But the letter's out there. You can find it. It's available online. Chronic non-cancer pain is one of the main reasons for the increase. So treatment of chronic non-cancer pain increased the average length of time opioids were prescribed, which then led to higher dosages and amounts per prescription. All right, so think of what that does to the availability. All right, and so one of the kind of little secrets out there is one of the groups that has to watch things most closely are realtors. Now, why would realtors need to watch how they show houses, and why would people need to watch realtors who show houses? When they show houses, one of the rooms in the house that they're showing off is what? The bathrooms. Where's the medicine cabinet? Bathrooms, kitchens. And so they found that when people are showing houses, they'll steal people's pain meds and opioids, and sometimes the realtors are doing it too. Crazy stuff. The good news, I'm all for finding good news in the midst of a crisis, right? Is that the medical profession has really started policing itself, and you've got governmental entities coming in that are also now saying, we're going to be watching how you prescribe the opioids. And they should. I'm generally kind of not a very heavy-handed federal government kind of guy, but this is one of those things, we've got to get a handle on this thing. And so one of the things that they've done is the number of prescriptions has really dropped significantly, which is a good thing. And the average number of pills per prescription has dropped, right? So hospital visits, you had 64% increase in opioid-related inpatient hospitalizations. Emergency department visits had a 99% increase, and this was back in 2014, 90 people per day were dying from opioid-related overdoses. 2015, that went up to 113 per day. The next year, it was 130 per day, and most recently, it's up to around 134 people a day. All right. And we've got to be careful about using the examples because we can become so desensitized to them, right? But when you hear people talk about, an airliner crashing every day, that's what we're looking at. And it's opioid overdoses. Now, total number of drug overdoses, we're right at the 200 people a day are dying from overdoses. So about 70% of the opioid deaths, of overdose deaths, are opioid deaths. About 60% of the opioid deaths are from the synthetic opioids, the fentanyl and carfentanyl. All right. 4 in 5 new heroin users started out misusing prescription painkillers. And in a 2014 survey, people chose to use heroin because prescription opioids were more expensive and harder to get. All right, so as we start clamping down on the availability and the access and the affordability of the prescription opioids, the heroin use has jumped up and spiked, and so now we're getting all kinds of problems related to that. Right, so we got a long way to go yet, and that's why we have to start thinking long-term recovery, and that's why I think a natural disaster kind of model helps me start getting my thinking in the direction of this is going to be a long-term thing. You know, buckle up and hang on, and it's going to be a rough ride, and we got a long way to go yet. All right, these are just some slides that illustrated what we were talking about. Number of opioid deaths total was right at 50,000, 49,000 last year. This slide is pretty helpful in that here's some more good news, right? All right, the bad news is the fentanyl and carfentanil is going up. That's the bad news. All right, where's the good news? Well, the good news is the prescription opioids and heroin, the deaths from those are going down. So you can see they're starting to curve downward a little, all right? Now the problem is that lurking behind this opioid crisis is a methamphetamine crisis. So we've put so much attention on the opioid crisis that people are cooking a bunch of meth, and now you got a methamphetamine deaths are going up. So we just have to face the fact that our culture is uniquely committed to addicting itself, and we've got to address those situations pretty directly. I think, honestly, I think it needs to start in the church. It needs to start with us. That's the best place for it to start. All right, number of people with opioid use disorder. Now, that first bullet point is an important one to remember. That's a lot of people. Roughly 21 to 29% of patients prescribed for opioids for chronic pain misuse them. So think 30% prescribed misuse them. Now, what's the other side of that statistic, though? Do your math. 100 minus 30 is what? Okay, 70% don't. So this isn't about throwing the baby out with the bathwater. This isn't about getting rid of all opioids. Some of my students are probably getting tired of hearing about my poor old mother. All right, but my 93-year-old mother, who died a couple of years ago, was walking around with 4 compression fractures in her back, and her status medically was so weak they couldn't do anything to help her back. So she had no option. She had no option but to use the pain medications. Now, she was dependent on those medications. She had developed tolerance, and she would experience withdrawal, all right? But, and this is what the most recent edition of the diagnostic manual, DSM-5, has done, is teased out dependence from addiction, right? So you can have tolerance and withdrawal, but as long as the meds are being used licitly, you don't get diagnosed with a use disorder, which is a good thing. My mother wasn't craving. Now, she needed it for pain, and when she started to hurt, she'd want her meds, but that was because of pain, right? She didn't have loss of control. She wasn't begging nurses or paying her caretakers to, steal other patients' opioids and bring them to her. And when she was living with Judy and I, she could have, done any number of things to increase her amount. Well, she didn't do that either, right? So she had tolerance and would experience withdrawal, but she wasn't addicted. Loss of control and craving are sort of the cutoffs for when someone's struggling with addiction versus dependence. Now, depending on how that dependence occurs, certainly that can be a problem. And the NIDA people really focused on brain disease. Even they hold out that there's a continuum of misuse that can be dependence but not yet addiction. All right, now they really go straight after the brain disease when you're talking addiction. All right, but so that's kind of where we are with that. Of those people, between 8 and 12% develop an opioid use disorder. About 4 to 6% who misuse transition to heroin, and about 80% of the people who use heroin first misused prescription opioids. All right. So all totaled up, recent data, a little over 2 million people with opioid use disorder. That's a good number of folks with opioid use disorder. Even more may be struggling, but not yet characterized by that. All right, so it helps to remember there's a process of addiction that generally people may go through. An experimentation phase, a couple of times of use, and a decision is made to either continue use or discontinue use. If use continues, typically addiction may go through a social phase. Most people, there are a lot of people who don't use at all. Using alcohol as an example, 30% of the adult population in the United States don't drink any alcohol whatsoever. So of the 70% of adults in our country who do drink, 70% of them don't have problems with it. Of the 30% that have problems, maybe about a third have severe problems, moderate to severe problems. So that same kind of pattern holds true, in most addictions. And in that process of addiction, just remember, most people won't progress past social use. All right. Now, this is theoretical, not diagnostic, all right? One of the critical change points for me as I think about people's use is when they start to attach reasons to the use other than the occasion itself, or like a glass of wine with meals is not a problem. But when I have a couple of drinks after work 2 days a week to help me relax, still not a diagnosable use disorder, but you've just attached a reason to the use, right? That's when I think someone enters into the medicinal phase of use. All right, I think that's a critical change point. Now, we aren't putting names on people, diagnosing them or whatever, but conceptually that's a change point for me, and an important one. So you can notice too that in that medicinal use, if I'm using alcohol at home increasingly to help me relax after work, that's more of an individual activity, not a social activity where others are present. Plus, I've got a lot of people at my house wanting to relax, right? Okay. So as it progresses on, think through the development of tolerance and withdrawal. And then when you throw in craving and loss of control, that's when it'll cross over into addiction and the addictive phase. So once addicted, George Koob has just done excellent work as a researcher in addiction. There's some people, if I saw them and met them, I'd kind of do the Wayne's World thing and just, I'm not worthy, right? He's one of those people in the addiction field, has just done tremendous work in the area of addiction, and particularly the neurobiology of addiction. And generally, he's made it very understandable. And so one of the things that's been helpful in his conceptualization is identifying, once addicted, the binge intoxication phase, the withdrawal negative affect stage, and the preoccupation anticipation phase. And he's identified different brain structures and pathways involved in each of these specific areas. And so where we are technology-wise, medical technology-wise, is medications are being designed specifically to affect each of these specific areas in the brain, all right? So, we're headed to some areas that may be uncomfortable for us, but we have to think about it, and I think just deal with the truth of, just like other parts of my body at times need medicine to help it out. Listen, I'm thankful for decongestants and antihistamines. I wouldn't be here today if we didn't have medicine. My body needed some help. So if someone's brain needs some help, I think we just have to remember there is a brain up here, right? Think biological, psychological, bio, psycho, socio, spiritual. One of the things that the big problem is reductionism. Some people tend to reduce things down to only or mainly biological. Others reduce it down to only or mainly spiritual. And all of me is in view of God's redemption, thank God, right? My entire person needs His redemptive care. I am not in my glorified body yet. I hope not. Right? So what happens to my brain when the rest of me dies and is planted in that ground? What happens to my brain? It rots like the rest of me. It's subject to malfunction. Now, one day I live in the hope, and this is where the church comes in. How important is hope? In all of counseling, but especially in addiction counseling. Man, look at the hope of, listen, your brain may not make it back from addiction. You may simply have altered your brain. And there's evidence that a number of people end up with permanent changes as a result of their use of substances. But can we at least provide the hope of, look, there's healing now and we're going to do what we can to get you there. But just like other disease processes, we aren't there yet. So you hang in there until, in the meantime. That's actually a sermon series title I've thought about doing. In the meantime. You get some mileage out of that, so, pastor types. All right. Process of addiction-wise, I think in many respects, the curiosity phase for a lot of people gets bypassed in the typical addictive process, right? Imagine going for, a teenager, imagine a sophomore having a sports injury, they go to the doctor, and doctor prescribes some pain meds, and then boom, it just activates this whole addiction thing. And, they were sitting on it in terms of their biological family of origin and stuff like that. There's addiction rampant throughout their family. They were behaving themselves. They went to the doctor, did what they did, and they took the stimulus of the opioid medication. It just activated all that stuff physiologically, right? I mean, there are a lot of people. Remember, a lot of people are getting there by way of prescription opioids, right? I think in a lot of ways, social use kind of gets bypassed with a lot of people in the opioid crisis, right? I mean, unless they're having parties on the surgical units, some people are just coming by it honestly, and there's not the typical phase of social use and things like that. I think in many ways, a number of people who don't fit the stereotype of the heroin opioid addict, I'm thinking that we've probably got increased, heightened senses of guilt and shame. People that had nothing to do with addiction now find themselves seeking heroin. I've done little sessions here and there and in some very rural areas, and I can't tell you, folks coming up talking about their 70-year-old aunt who's out there looking for heroin. I mean, this is an amazing thing. It really is an astounding thing. And just hearing those kinds of stories over and over again, it's an amazing thing. I think too that there might be, I've been trying to check this out, I've had a hard time coming up with a date on this, but I'm wondering if when you consider all of the different types of use disorders, I'm wondering if there might be higher rates of moderate and severe rather than only mild severity. I'm wondering if more people are drifting quickly into the moderate and severe use disorder. That's a hunch, but I haven't been able to find that one out. I don't want to get too lost in this brain biology, but just remember, there are pleasure centers, there are pleasure structures in the brain. The ventral tegmental area is one of them. The neurotransmitters, dopamine is a primary one involved in the experience of pleasure and euphoria. So those get activated. The nucleus accumbens is a structure in the brain that focuses on, helps us experience pleasure, involved in reinforcement and reinforcement learning. Basic behavioral principles are very helpful to keep in mind. Prolonged exposure can actually change set points in the brain. So think homeostasis. Think about that steady state in the brain, trying to maintain that. Chronic use can create new set points, and look at what that could do for tolerance. And the new normal is an addicted normal, right? All right. So then there's also the hypothalamic pituitary adrenal axis. The HPA axis is kind of that stress response axis. All right. So as someone starts experiencing a decrease in euphoria, but an increase in the painful symptoms of addiction, the body's under stress, the stress response kicks in, and that's part of the picture. So if I take something and I experience pleasure, that's positive reinforcement in behavioral terms. If I engage in a behavior that reduces unpleasantness, right, that's negative reinforcement. And so you can see pretty quickly that from a behavioral perspective, you're getting positive and negative reinforcement working together in the direction of addiction. And so you can see part of the challenge is someone's brain resets itself. Part of the challenge is they've got to re-experience pleasure, and they've got to re-experience managing and tolerating unpleasant situations without the use of drugs, without the use of the opioids. Now, if it took a while for the brain to become addicted, it's probably going to take a little while for the brain to become unaddicted. I believe in a miracle-working God. Some of you are familiar with my story enough to know I'd better be familiar with his miracle working. He's done some amazing things in my life. I believe in instantaneous healings and things like that, but I also believe he allows us to struggle. And I think we have to create a loving, Christ-centered context to help people suffering from addiction. All right? Okay. We aren't going to learn all about pain today. Just know that pain is part of how we got there with the opioid crisis. I'm just going to blaze through this. I'm not even going to bother. We need to get somewhere. Just know there are different structures in the brain that when you're dealing with chronic pain in the brain and the brain's perception of pain, right? So if I smash my finger, that's really not where I experience pain. I don't experience pain in my finger, I experience pain in my brain. And so what happens is we've got ascending pathways up to the brain, and we've got descending pathways down to the brain. And there's opioid receptors all up and down those pathways. And so part of the reason that prescription opioids for pain management have the effect that they do is they operate on those endogenous opioid receptors that God built us and designed us with. See, look, we got to remember, God designed us to experience pleasure, right? There's nothing, this is going to sound kind of crazy, but there's nothing really that aberrant about people seeking pleasure in their life. We were designed for it. And eternally, sure, all of life to God's glory, and then what do we do with his glory? What is God in his glory when we're there with him? Is he going to enjoy that? And does he want us to experience the pleasure of being with him and everybody else forever? See, we were intended for pleasure, right? We're designed for it. So we just got to accept the fact our brains have been impacted by sin just like the rest of us. And so my pleasure centers in my brain are subject to the same kind of stresses and malfunctions that everything else is, Just gotta get there. This is an important slide for a number of reasons. The pain matrix, talking about all this physiological connection and stuff, the pain matrix is not only processing physical pain, but also emotional pain. So this is where the counseling piece comes in very clearly. As, for example, in connection to social exclusion, there's accumulating evidence that severe physical and social pain may alter brain function and that such changes may contribute to the transition from acute to chronic pain. and to the comorbidity between chronic pain, depression, and anxiety disorders. All right, so I'm preparing to do a webinar in a couple of weeks on co-occurring disorders and those that are most likely to show up in the context of opioid use disorder, right? But do people who are struggling with opioid addiction need help other than just for their brain? This says they need social help, psychological help, and spiritual help, not just simply biological help, okay? So this is where we're going to transition into how the church can help. And this is one of the big challenges. I believe this is the benchmark issue for the church to face today. What do we do with medication-assisted treatment? Right? What do we do with medication-assisted treatment? It forces us to deal with the fact that there's a brain up here and that brain might need some help. So we're going to talk a little more about this when we get to the perspectives here in just a second. But the evidence is just too clear. There are many people that their best hope is to have medication to help them with their brain as they're dealing with their opioid addiction in the context of counseling and social support. The medication-assisted treatment only by itself is not a good way to go. That's just not the best way to go. The other side of that, though, is someone whose brain is addicted, only the psychosocial supports aren't the best way to go either, right? So if the medication-assisted treatment is necessary, it needs to occur in a holistic context. And so just simply be fair about this thing. Apply it the other direction. Don't be reductionistic, right? Biological support is part of this picture. And when you look again at the numbers of people addicted, the rates that this is happening, the number of deaths, we got to do something. And so the evidence is really accumulating that medication-assisted treatment done well is very effective. Very effective for a lot of people who otherwise wouldn't get on a path of sobriety and recovery in their life, but would remain addicted, right? So I think this medication we have a hard time in the church is still struggling with the whole idea of addiction anyway. Now we're talking about using medications that may be in the same drug class to help you get over that addiction, get through that addiction. That's a big challenge. But if we're going to deal honestly, we have special revelation in God's Word, and we've got general revelation in God's works. And the research from God's works is that medication-assisted treatment done well is very, very helpful for many, many people. So it's not like the church has to do medication-assisted treatment, although we might want to think about that, right? But can the church support that? We'll lay hands on somebody struggling with cancer. How about lay hands on somebody's head and pray for healing for their brain? Why don't we do that? Some of y'all know my brain might need a little praying, so, right? Methadone, buprenorphine, naltrexone. Basically, these medications, in many ways, they turn down the amplitude and extend the frequency. They get in slower, it's a lower burn, they get out slower, and they block effects. They block euphoric effects, they block withdrawal effects. So what it does is it extends out and smooths out the effect of the medication, giving them opportunity to make better psychological, social, and even spiritual decisions. It gives them a little more room to not be driven by the addiction. And so in general, that's kind of how the medication-assisted treatment works. We've got all kinds of help available for folks, all kinds of treatment modalities that many of you are familiar with are inpatient, residential treatment, outpatient counseling. We've learned a lot about pain management. The whole issue of co-occurring disorders is pretty huge. Folks who struggle with use disorders, a higher percentage will have a co-occurring some other mental disorder, particularly depression or anxiety. And we know that people who are struggling with other mental disorders have higher rates of addictive disorders, right? So we just have to realize we're dealing with both. Got a number of different modalities available. See, the help is out there. We've got a lot of information on how to help. It really just boils down to, will we? It's a question of our will. Are we going to get involved? Then the next one is, if so, how? Well, we've got information on how to be involved. And it gets back to, will we? Right? If we know what we've got and we know what to do, then why won't we get involved? Okay. Federal government's responding. It really is an astounding thing. The Faith Opportunities Initiatives, the partnership center of the Department of Health and Human Services, they are begging for the church's involvement in responding to this crisis and severe mental illness, as well as the opioid disorder and prison reform. So those three kinds of things that you've been hearing a lot about lately, there are some very active efforts at the federal level, and they are begging for the church's involvement. It is different than the faith-based initiatives back in the early 2000s, where it was sort of like, we're the federal government, how can we help you? This is a different thing. They are saying, listen, you have to help us address this thing. There is no better way than to have our faith communities meaningfully involved in this situation. And so now we've got an invitation. And so it's back to that question, are we going to show up? Right? It's amazing. They've got a toolkit for those of you who are interested, live in other communities. The Center for Faith-Based and Neighborhood Partnerships is the Partnership Center. They have a toolkit available for download. It's your tax dollars hard at work. These are already paid for. The Blue Ridge Parkway and the Samson NIDA sites. Those are good uses of my tax dollars, right? They've got some excellent resources, and this is one of them. Partnering with SAMHSA is an excellent thing to consider. The Substance Abuse Mental Health Services Administration and the Partnership Center. There is grant money available for those in faith communities wanting to respond. There are people who are monitoring distribution of funds to the states, and they're sort of auditing, are the states getting faith partners involved in the response? All right, so that kind of stuff is going on. All right, so perspectives. Back to that biopsychosocial model, socio-spiritual model. Holistic view of persons, right? That's what we've got to keep in mind. All of me, it's not just my spirit that lives forever. Again, thank God my body's involved in that picture, and my brain, and my emotions, right? Choice, willpower, and personal responsibility matter. They are important, therefore sin is still involved. So if the church has to continue to frame this as a sin problem, okay, let's deal with the sin problem, because that's still part of the picture. Let's get a little more discriminating of what kind of sin are we talking about. Are we talking about personal sin? Are we talking about the sin of others against someone? Think of one of the most robust findings now that people are really digging in and looking at it is adverse childhood experiences and those who have addiction. And you're talking like 85, 90% of those with addictive difficulties will report adverse childhood experiences. Wonder if the church can be involved in the healing of that kind of damage. Wonder if the power of Christ can reach that deep into someone's soul, that the self is, sometimes not only healed, but it's almost like it's generated, right? I mean, to watch that happen It's an amazing, amazing opportunity we have. The idea of infirmity, I've been open. I'm not anti-disease model. I'm anti-disease model only. I'm not anti-nouthetic counseling. I'm anti-nouthetic counseling only, right? It's this only thing that bugs me. That's where I've got a problem, right? So think of addiction as an acquired disease. Personal sinful choices that actually need confession, repentance, forgiveness, all that, right? What if those choices, I was making sinful lifestyle choices and I developed type 2 diabetes. Then I have a come to Jesus meeting at a revival, I get good and revived, and I'm no longer engaging in sinful personal lifestyle choices, but I still have type 2 diabetes. Am I living in a perpetual state of personal sin because my pancreas doesn't work right? I don't think so. So think of addiction as an acquired disease of the brain, much like heart disease, right? See, give ourselves a little bit of room to do this more holistically without throwing bombs at one another, because we've got to do this differently. Now, what that means is forgiveness and cleansing is possible even if remnants of the disease remain, right? They're going to need support. They're going to struggle. And look, relapse is part of this, but relapse is also part of heart conditions. Relapse is also part of diabetes management. Think of this one, brittle diabetics. They can be doing their insulin, they can do everything to the letter, and all of a sudden their blood sugar just goes out of whack. They don't even know why, it just does, right? Imagine somebody's brain doing that because it got addicted. Brain subject to that same kind of malfunction. All right, the blind man and the elephant parable, right? 7 blind men. This is actually kind of multiculturally, incorrect, but blind man and the elephant, each one has a different piece of the elephant, so you ask each one, describe what an elephant is. Well, an elephant's like a snake, an elephant's like a wall, an elephant's like a tree trunk, an elephant's like a spear. And so somewhere along the line, God prompted this question in my mind, and I went, what if all of a sudden God healed their blindness? And all of a sudden these 7 blind men had their sight restored. I wonder how they might interact with those other 6 people who have their perspective of the elephant now that they can see it. I wonder how they might describe the elephant now. And see, I think we have to have those kinds of perspectives. So I believe the church can help. It starts with pastoral leadership. And I mean this in a practical way, not like a, technical theological way, but I put that above prayer simply because it's pastoral leadership and pastoral prayer that is that vitally important. You get the pastors talking from the pulpit. You get the pastors praying from the pulpit. You get pastors encouraging ministry teams to go to treatment centers, not just hospitals, right? Pastoral leadership is the key to this thing. Imagine the church in a community that offers a place for grief, for people that have died, people who have lost loved ones to this crisis, because they're there. I've lost a couple of friends, hunting partners. This first opioid symposium that we've kind of pulled together lately, a little small rural community lost 15 people in 12 days. A rural community, 15 people in 12 days. And so when we were talking about pulling this together for the first time, I said, look, we've got an entire community that's traumatized, right? What's this half-day stuff? Shoot, let's give them a whole day. Let's get after this thing. Let's go up there and love on these folks, right? I think we have to develop our theology. Physical body, suffering, right? Ideas of healing. What do we do with shame and guilt? Stigma is a huge area. where imagine the church becomes open within itself about what's going on and then invites the community to come in and experience that in the context of a shame-free environment that's full of hope when you got to deal with the other stuff. Man, doing prevention is a huge way the church can be involved. Church helping with access to treatment, right? Somebody has a hard time paying their hospital bill. People don't, they don't want to necessarily, but they'll ask the deacon fund to help them out. What about helping out with going and getting somebody to treatment? Get them good care. Social supports, co-occurring disorders, child care. Imagine providing recovery housing, right? All kinds of, tax benefits that might come from a charitable gift to a church of a home that could be used for recovery housing to help people get back on their feet after losing everything. Can the church do these things? Well, sure. Now we've got the ability. It's really leaving us without an excuse. You know that. We may still have an excuse, but not a good one. Consider the church as a wellness center. Sick people becoming well, right? And imagine being a wellness center in the context of your communities. And then imagine taking the lead in your community, pulling together, addressing the number one health crisis in our country.